Our first speaker is Dr. Tim Matthews, and Tim's going to be speaking about hearing loss and common ear problems. Tim's a specialist otologist, neurotologist and general ENT surgeon with special interest in endoscopic ear surgery, hearing device implantation, advanced ear surgery, and general adult and also childhood ENT disorders. So Tim started at St Vincent's this year after returning from Canada on his fellowship. So please make him welcome.
Rightio, thanks for the introduction. So I was just going to talk about obviously ear issues in general, but obviously already kind of been introduced, but obviously I'm mainly interested in the ear aspect of ENT, but obviously happy to do general stuff, and as we said, endoscopic hearing implants and teaching for my research interests as well. Basically, I'm going to go through 3 clinical cases for the presentation. I'm going to keep it fairly basic and practical, so obviously feel free to jump in and ask anything if you're wanting more clarification, guidelines, or more in-depth wise. Obviously, I know everyone has different clinical experience, and some of you obviously extremely experienced with the basics from the ear side, so please pipe up, ask me things that you want clarification on. Equally so, obviously happy if you wanted any more resources either for your practice or guidelines, etc. going forward, just send me an email. For the first case, I thought I'd just talk about guy Jason, who came along to practice, and he basically was a 48-year-old plumber who'd been working fairly hard. He was intermittently having decrease mainly in his right ear, but also the left, and it was usually after he jumps in water. He's been a keen swimmer throughout school and when he was doing his apprenticeship, and he now wears earplugs just because of the issues he's had. He also had 2 to 3 sort of painful episodes with his ear in the last year before he saw me. And really that was his presenting sort of complaint when he came in and I asked him what was going on. So I just thought it'd be a good moment to pause and sort of think, as far as if he saw you in your practice, you know, what else you'd be asking him history-wise, wanting to get out of him, having a think from your perspective, what you'd be doing, what you'd be looking at, what the important diagnoses are, or the most common things, and obviously the things you wouldn't want to miss. I can give you my basic approach, obviously, to ear things as far as trying to encompass everything. And like I said, I'm not the smartest guy, I'm a surgeon, so I like to keep things simple. And I really have 6 otological symptoms that I reliably ask patients about regardless of what ear issue they come in with, just to make sure that we've covered everything. So obviously otorrhea, or discharge from the ear. Otalgia, so ear pain, you know, the usual questions about pain, severity, onset, duration. Obviously hearing loss as far as how progressive or sudden the hearing loss is. Obviously facial weakness, as we all know, the facial nerve running through the petrous temporal bone is often affected in more severe ear disease. And I think even just from a documentation point of view, it's good, if not just from a medical legal aspect, to say that it was functioning when you saw them in the clinic. Vertigo and obviously gait imbalance, given the vestibular system in the inner ear is linked, and tinnitus. And really, you know, they're part of my rattle that I just use when I'm getting a bit stuck in an ear history, just to make sure that I've ticked all of those boxes as far as things to assess and at least have thought about. And obviously you guys will have clinical experience as far as knowing what's important out of those. More detailed things, obviously, when we're getting more complicated. Obviously, medications, usual ototoxic medications that we all know. So, you know, gentamicin, cisplatin, chemotherapy agents, aminoglycosides if they've had hearing loss. But then also ototopical use if they've been using over-the-counter swimmer's ear drops, have they been using other ototopicals, have they been ear candling, have they been basically sticking anything in their ear that we want to know about. Antibiotic usage, obviously, as far as judging severity of infections, people often, obviously I've had a bit of a red ear and a cold, but they've never needed antibiotics for a middle ear infection versus purulent otorrhea requiring antibiotics regularly. And anticoagulants, obviously, if I'm going to start cutting them. Noise exposure wise, obviously it's dependent on your area. I kind of have people look at me strangely in Darlinghurst when I ask them about guns and explosives, but in Canberra where we're at down the road, obviously from ADFA, you would be stupid not to be asking people about that. And occupational, both noise exposure and barotrauma. So obviously air hostesses, pilots, down in Canberra, submariners, getting in submarines. I've learnt lots of fun terms. Snorkeling is where the submarine comes up and the little bits out the top, and they actually skim at sort of 15 to 20 metres, which is the worst for the ears because you're going from 0 atmospheres or 1 atmosphere to 2 atmospheres quite quickly. Loud music exposure, obviously with recurrent concerts. The main thing, it's always difficult when patients are reporting whether they've been exposed to loud music and how frequently. Often post-exposure tinnitus and a decrease in hearing is a good subjective indication of damage to the ears because they have the temporary threshold shift from loud noise exposure, they get ringing, decreased hearing, and then it comes back to normal. They do that long enough and then gradually their inner ear will be damaged and they will have noise-induced permanent hearing loss. Prior surgery, obviously, people often forget grommets that is an operation because it's so small, but I remind them, particularly in childhood, and they may or may not know. And obviously the other end of the eustachian tube, so surgery on the nose or an adenoidectomy, can often cause scarring of the nasopharyngeal portion of their eustachian tube. Prior audiological assessments and hearing aid usage are very useful if they've gotten them, particularly if you're trying to decide if they've had a sudden hearing loss or a gradual hearing loss. It's great to be able to say, oh look, I've got this 5-year-old hearing test, or I see my audiologist every year and I can get the last 5 years hearing test from them. So I often seek corroborative history from audiologists as well. Obviously, if there are family history of specific syndromes, we're looking at things like otosclerosis, which tends to be inherited, and usually they'll be able to tell you, yeah, mum had an operation on her ears for her hearing when she was in her 30s, or yeah, mum had to wear a hearing aid from the age of teenage years before I even knew, was in the world. And then syndromic disorders obviously go hand in hand with a lot of ear issues. So really, I think they're the more in-depth points from the background. So I don't know if anyone had any questions from the history side of things or worries about the history side. But that's usually my broad overview. And obviously, if you're suspecting a particular condition, we'd go into more detail about that. I keep my ear exam simple as well. I mean, obviously the otoscope is the workhorse, but when we're examining ears, we're often using the operative microscope because we have 2 hands free, binocular field of view. It's a much nicer view, obviously, for the eardrum. But looking at it in the clinic or when I do remote work, I literally just work from outside in. So obviously just looking at the usual almost Talley and O'Connor type general inspection, looking for facial weakness, asymmetry, obvious erythema, edema, signs of systemic issues. And then really the external ear, signs that either someone's been there before, in front, around the ear or behind the ear. So an incision pre-auricularly, a widened external auditory meatus that would suggest a meatoplasty or someone's enlarged the ear canal, or a post-auricular incision which is really hidden in behind the crease of the ear, which is often the workhorse of all our major ear operations. They might have had a very big cholesteatoma surgery and just have a small incision behind the ear. Then obviously having a look in with the otoscope, and you're really saying going from the external canal down to the tympanic membrane. If the tympanic membrane is semi-transparent, as you would normally expect, seeing if you can assess any of those middle ear structures through the drum. And then obviously thinking about the inner ear hearing test, by which I mean it's a good point to say, well, I've checked the outer ear and middle ear, how do we check the inner ear? Tuning forks and free field hearing tests I think are really key and probably underutilised, both in ENT practice and in general practice as a good screening tool, particularly where audiology isn't freely available or patients want to know whether they need to spend money on a private audiology assessment. And then vestibular tests obviously being the other part of the exam. Does everyone know what a vestibular ocular reflex is, or the head thrust manoeuvre? People heard of that? So the vestibular ocular reflex is a short reflex from the inner ear vestibular system to the eye. It's how we keep the eyes fixed on a target when we're moving our head quickly. And Professor Halmagyi at Royal Prince Alfred Hospital was one of the world pioneers in basically quantifying this test as being a really reliable, reproducible clinical test. So all we get people to do is focus on your nose, get them to relax their neck, and then gently but quickly turn their head 15 degrees. If it's someone older with neck issues, I start out to the side and work back to the middle so that you don't hurt their neck. And you're looking for their eyes staying directly on the tip of your nose. If you turn their head quickly and half a second later their eyes flick back towards their nose, it's a sign they've lost the reflexive following of your nose and they've had to consciously look back towards your nose, and it's a sign of vestibular weakness. So basically if you do a quick head thrust and their eyes are playing catch up to look back at your nose, you know they have a vestibular weakness. The other interesting thing about the test is it's side sensitive. So if you turn their head quickly to the right and they have to catch up and look back to your nose, you know that their right vestibular system is weak. If you turn their head quickly to the left and they do a quick look back to your nose, you know their left side is weak. So, yeah, is anyone happy? Can I do it on someone here?
You mean like if you move them to the right?
Yep.
It's their right.
Their right ear, towards their right ear. Can I demonstrate it on you quickly? Is that all right? So basically, I just get them to face me, and I quite like them sitting down and looking up because the lateral canal is in that plane of 15-30 degrees. So I say,
Still on the nose away.
yeah, I say, look at the tip of my nose, relax your neck. I'm just going to gently but quickly move your head. And then I turn their head to the right. They should stay focused on my nose the whole time. If their eyes do a catch up, like half a second later, the right vestibular system there would be weak, or the right lateral semicircular canal. Same again, if you do it to the left and their eyes do a little catch up, it means the left vestibular system is weak. The important things is it has to be quick, so it has to be a little quick flick. It only has to be a short 15-degree arc, and they can't be predicting where you're going to move them, or otherwise they'll sort of prejudge it and move their eyes well. So it's a good, simple, quick test, and I'm happy to send around a slide about how to do that. So it's used, the head impulse test is used as part of the emergency assessment of patients to determine whether they have a central cause for vestibular issues or peripheral cause, and it's actually that combined with a few other clinical tests is as sensitive as an MRI at picking up a posterior circulation stroke, they've shown. For quite a few different papers, so it's called the HINTS examination. Head impulse test, the type of nystagmus, skew deviation. Yeah.
There's another test. There's another test that we do.
Yeah.
We get a patient to look at us and we show them the light.
Yeah.
And to follow the light.
Yeah.
If you follow the light to the right, there's a nystagmus going to the left. Then you know it's a problem on the left.
Yeah, so that's trying to determine gaze-evoked nystagmus. So basically when they're looking at following the light, it's trying to tell whether they you have an nystagmus that is irritative, so it's causing the eyes to be pushed away from the lesion, or whether it's a non-vestibular cause for their nystagmus. So that's trying to quantify nystagmus. This is trying to quantify vestibular hypofunction. So this is the kind of patient that has a sudden sensorineural hearing loss and their vestibular system just doesn't work. They're not acutely vertiginous, but they just feel off balance, they've not done well. Or someone, say, that has had gentamicin and it's killed their inner ear system, so they haven't had an acute vestibular episode. You can use the head impulse test very well. But say if someone does have active vestibular neuronitis or an inflammation in the inner ear at that point, you're quite right. If they look towards that ear, they'll get much worse nystagmus. If they look away from that ear, the nystagmus will be a lot less. I could talk for an hour just about vestibular assessment and the vestibular physiology, because it certainly is complex, and I'd be happy to do another talk on dizziness, because I certainly see a lot of that as well. But yeah, so I certainly would commend the head impulse test to you as a good thing to add to your examination armamentarium. Like I said, I think tuning forks, I think these should be, in all family physicians' clinics. They're a simple test. You can get one for $30 on eBay. They're not an expensive piece of kit, and it really does make a difference, because, as you know, this is harking back to sort of primary training, but the difference between a conductive hearing loss and a sensorineural hearing loss really is like the localizing sign, or the difference between upper motor neuron, lower motor neuron, analogy in neurology. So anything, and I think this is from Murtaugh's book, but anything from the middle ear, so the ossicles, middle ear fluid, outwards will give you a conductive hearing loss. The oval window, which is where the stapes sits in the inner ear, is the junction between your inner ear problems and your middle and external ear problems. So really anything from here out will give you a conductive hearing loss. Obviously glue ear being a common one that you would see, perforated eardrums, otitis externa, those ones where patients come in and say, I've just got a blocked ear. That's what we're trying to differentiate between a serious central cause for their blocked ear, which would be sensorineural deafness, which could be, rarely a vestibular schwannoma or acoustic neuroma, or it could be, some weirder and wonderfuler things. So just to review, I'm assuming everybody has seen this at some point, but I certainly got confused many a times in my training. Weber's test is if you have a bad ear. If someone comes in and says, I've suddenly can't hear out of my right ear, and you're wanting to tell if that right ear deafness is conductive or sensorineural in nature. Is this, a glue ear that you can wait and watch for 2 or 3 months? Or is this a sensorineural sudden hearing loss that is a dead ear, that's an emergency, that needs steroids, that needs to see an ENT surgeon within 3 days? So it's a very useful test. Basically, if it's a conductive hearing loss, it goes to the bad ear. If it's a sensorineural hearing loss, it goes to the other ear. If you ever forget it and you're not sure, then you can, if we're doing the René's test is the next one, this is trying to differentiate between both a conductive and a sensorineural hearing loss. Again, you're comparing bone conduction, where you put the tuning fork hard on their mastoid bone or their forehead, to air conduction and saying which is louder. So in a normal ear, using your eardrum and your bones should be the most optimal mode of hearing. So normal hearing, air conduction, or in next to your ear, should always be louder than sticking it on the bone. If you have a a conductive hearing loss, like a big plug in your ear, that's blocking the sound vibrations from getting to your eardrum, but the bone goes straight to your cochlear and you can hear it much better. If you ever get confused about which does what, just give yourself a conductive hearing loss. Stick your finger in your ear and put the tuning fork on your head and go, oh yeah, it's localizing to that ear. So it's an easy memoir, which I tell to all the residents. So back to Jason. Yeah.
What frequency should you tune for?
512K is the standard tuning fork that we would all use, so 512 kilohertz, which is C, just below middle C. They tend to go up in increments, so 256 would probably be the next most common. Vibration sense is obviously 128, so it's much lower frequency. And if we, in the olden days, testing for otosclerosis, and when we would operate on them, you'd test multiple frequencies because they're obviously lost depending on how severe their conductive hearing loss is. Going back to Jason, so he obviously had the blocked ear that was intermittent, right side or left side, often after water exposure. We go through and do all of the tuning fork tests. One other examination thing that I didn't mention in the little rundown or go into great detail is free field hearing test. So this is just to get some kind of quantification. Can I demonstrate on you? Yes. Is that all right, Tim? So all I do with the patients is pump their opposite ear so it masks the sound in the ear that you're not testing. Cover their eyes so they can't read my lips and say, I'm going to say some numbers. Can you repeat them after me as I say them if you hear them? Don't worry, I'll get gradually louder if you don't hear it. So then all I do is go 13 and get them to repeat it. 45.
45.
32.
32.
There you go. You probably have normal hearing in the left ear. If they didn't respond, I'd go to 15 centimeters, whisper a few numbers. I go out, speak at a normal volume, 13, 45, 78, 13, 14, 5, 78. If they can't hear that, they have a very severe hearing loss in that ear, most likely. Okay. Once you start to get above a normal conversational tone, you will overcome the masking in that ear and they'll just start to hear you with their ear, even though you're rubbing it and trying to hide that ear. So that's a simple gauge, if you like. Are they really that deaf? How am I going to judge this? So I often do that if I don't have a hearing test on the patient that I'm seeing. His face was moving normally. That reflex we tested was normal bilaterally, so it's unlikely that he has a significant inner ear pathology given that his tuning fork tests are normal. He has normal level of hearing just with a whispered test, and his face is moving normally and his inner ear reflexes are intact. And then when you look in the ear canal, you can see this. Does anyone want to tell me what's going on with the ears? Obviously, great. So we can just see remnant drum there. That's the fibrous annulus. You can see the thin strip of the drum in the classical location, posterior, inferior, anterior, inferior, and then a superior exostosis, almost like the Mercedes-Benz sort of sign in the middle. So what's the plan for exostoses? Do you need to do any tests for them? How do you usually manage them? Does anyone want to say what they normally do? They see someone. Yeah, I mean, yeah, you can. You can just refer them on. From a testing point of view, if I see them, I mean, often I'm getting a hearing test if I'm contemplating operating on them or if they've had recurrent issues with their hearing. We often wouldn't get a CT scan. Some people might if they were going to operate on them, but it's a fairly straightforward, simple problem unless you're worried about an anatomical variation or some kind of thing that's going to be an issue at the time of surgery. Audiology should hopefully look like this. So obviously most normal hearing is above 20 to 25 decibels. An audiogram goes from typically minus 10 decibels down to 120. It's a referential scale. So this is comparing people's hearing to a group of 25-year-old guys, I think from the Irish Army like 80 years ago, and they all checked their hearing and said, okay, what's normal? That's normal. So that's why you can be minus 10. You can be better than the average 25-year-old man. So you don't have negative hearing, you're just better than the reference level, which was them. So anything above sort of 25 is considered normal in adults. Some people use 20, anything above 15 in kids under the age of 16. This is a CT scan of exostoses, not that I'd expect you to see. So obviously on a CT scan of the petrous temporal bone, you've got the nice mastoid, which is nice and aerated, or like an aero bar with lots of bubbles of air in it. there should be lots of those little trabeculae of bone in the mastoid rather than very thick sclerotic bone or fluid opacification or destruction of that normal architecture. So that's looking like nice, healthy ears that haven't had chronic inflammation in the mastoid, basically, to my eye. And then you can see those lumps that are sort of sticking out from the ear canal on the CT scan. So treatment-wise, really, not everyone needs to see us, particularly with early exostoses. That guy, and with the issues he's having, I think is definitely appropriate to see an ENT. But the conservative management, if you're seeing someone who's a 20-year-old surfer that's surfing a lot and maybe had an episode of otitis externa that you cleaned and fixed, and he's saying, you know, oh, people have had surfer's ear or bony growths around me, how do I stop it from happening? We know earplugs can help prevent it. Cold water exposure causes the exostoses to grow over time, and prolonged earplug use tends to prevent their growth. Basically, if you surf more than 5 days a week for 5 years, you will have early exostoses, and the exact prevalence varies greatly, of course, depending on the population that they've tested for the prevalence. You can use drying or acidification agents, particularly if they've got moderate exostoses and they get a bit of water trapping to try and get rid of the water. So swimmer's ear acetic acid drops basically just help that water evaporate, particularly if an earplug falls out and they're struggling to get the water out from behind those exostoses. Obviously they can stop surfing, but most surfers will rather jump off a cliff than do that. And obviously if they have wax impaction, they can have it cleaned out under vision. I wouldn't go irrigating someone with significant exostoses because you're likely to lead to water trapping. And obviously we can chop them out if they're getting recurrent water trapping, infections or significant hearing loss. Hearing loss to me is almost a bit of a red flag with an exostoses. They have to be completely and utterly blocking the ear canal to cause a hearing loss. So yes, if the wax is built up and completely plugged in between the exostoses, or if they've got an otitis externa and they've swollen shut, it'll be an earplug. But even if you've got, you know, 0.1% of the ear canal air getting through, that's enough to submit to get vibration of air, and you shouldn't have a significant conductive hearing loss. So sometimes things can be going on behind the exostoses if they've got a significant hearing loss. And like we know, there's grading from a normal eardrum down to a little bump to a couple of bumps to really full. Not just humans that get exostoses, but it's really human species. So this was a paper published a little while ago about Neanderthals in ABC, picked up on it in quite a few papers, basically saying that Neanderthals were in the water because they had exostoses, and the predominance of exostoses in the Neanderthal fossils was like near 70–80%. They're all like, oh, they're probably in the water a lot. Sorry?
Keen surfers.
Yeah, keen surfers. I think they were after the fish at that
Still
point.
are.
Yeah. But basically, all of the ancient human species form exostoses. No animals, as far as we know, form frank exostoses, though they do have some bony growth. And it's thought to be a protective mechanism for the eardrums to prevent damage to the eardrums. But we don't really know why they form other than the physiology behind it. So does anyone have any questions about exostoses, management, that patient, or what we would do? No, I imagine you see that a fair bit, so probably all over it. Next one, Albert, 68-year-old barrister who comes into the room. He's had long-standing hearing trouble in both of his ears. He's missing things at work, had a few embarrassing incidents. He's troubled by tinnitus in both of his ears. Obviously, you know, we've got to dive a bit deeper into his history and his examination. So I think, what are the pertinent points about his hearing loss that we'd want to know? What are the sorts of things that you'd be looking at in someone that's had hearing loss with that sort of a history, long-standing or gradual onset in both of his ears? Obviously, you guys see this all the time, so I'm not going to teach you to suck eggs, but he's never tried hearing aids. He's never had a hearing test. His balance is fine. He's not had any other significant ear symptoms as far as pain, discharge. His family doesn't have any real otological conditions. He hasn't had any surgery, trauma or noise exposure to his ears of note, but he does have some mild hypertension and cholesterolemia on medication.
How long has he had it? Was it sudden or was it gradual?
So this is gradual over many years, so insidious on onset, so over many years, gradual hearing loss. And the tinnitus gradually increasing over time.
Any noise exposure?
Yeah, so no loud noise exposure. He's, been a well-behaved lawyer in an office job most of his life, not listened to loud music, not been shooting machine guns in his spare time. No family history or of ear issues or tumours. So I don't know if there's anything else people would want to know from a history perspective for him.
Is he a smoker?
He used to be a social smoker and quit, I think it was in his 25 or something, so he's not smoked for 40 years. Medications wise, he doesn't take aspirin regularly, which is something I ask usually from a tinnitus point of view. There's a good linkage between aspirin usage and tinnitus.
How much aspirin do you take before you get tinnitus?
So it is usually dose dependent in that we know that higher dosages increase the number of people with tinnitus,
Is that reversible when you stop?
Yes, it is. So that's certainly if if you started someone, on 300 milligrams or 100 milligrams of aspirin and they suddenly had tinnitus, you could stop it and see if it gets better, which is the good thing about aspirin-induced tinnitus. He's not a surfer and not had much water exposure. Don't
Boxer.
boxer? No. Why do you ask about boxing?
You bang on the ear all the time.
Yeah, so boxers, I've seen a fair few cauliflower ears and obviously hematomas. I've not seen any petrous temple bone fractures from boxing, interestingly, or martial arts in general. Usually motor vehicle accidents, because the petrous temple bone is one of the hardest, it is the hardest bone in the body. We argue with orthopaedic surgeons about the femur and tensile strength, but it's, one of the least compressible bones.
Does he use drugs, especially cocaine?
No cocaine usage. With illicit drug use, as far as the hearing side goes, I'm not aware of a great association between cocaine and hearing loss, some of the, it's usually septal perforations and nosebleeds from cocaine. Intravenous drug use, there are some that are associated, usually it's contamination as well for IV drug use. Examination wise, so coming back to a theme, his tuning fork tests would be consistent with symmetrical hearing loss in him, because we know that he's having trouble with hearing. All of his cranial nerves examine normally, and I usually do at least run through a facial nerve exam quickly with most ear disorders. But in anything where I suspect an inner ear disease or pathology, I will go through the other cranial nerves. So just quickly their eye movements, check their tongue and palate move normally. All of his other things look normal. What do people think of these eardrums? We're up to 7:30. Yeah, so they're normal. So I explain to patients when they ask me what I've seen on their ear, or if they, I put it up on the screen and they got a picture. I say, eardrums are a bit like frosted glass, yeah? So you can see through them, might not be perfect, and obviously depending on the condition it can be more difficult to see through it. That's the long process of the incus through there. I can make out the stapes tendon because I've cut it many a times, and the stapes sitting under there. That's obviously the malleus umbo going up to the lateral process of the malleus. That's the pars flaccida above the lateral process of the malleus. That's the pars tensor. This is the bit that most people will not look at unless they really angle down and look up with an otoscope, or get the patient to put their ear to their shoulder on the opposite side, because it is hidden right up the top. So what do we need to do with him? Any thoughts? Yeah, so I think, you know, that's really going to be step one, you know, with anyone that's got suspected hearing loss, audiology. Okay. So that's his hearing test. Does anyone know what that hearing test shows? Roughly?
High frequency.
Yeah, so high frequency sensorineural hearing loss, might call it sloping in nature. It's symmetrical, so there's no significant asymmetry. Audiologist recommends a trial of hearing aids. Would you be happy to do that? Do you think he needs any further investigations or treatment at this stage?
Given his age, would you do a CT scan?
So there's good evidence. I've forgotten the website that has, what's the name of, anyway. Yes, thank you. Choosing wisely. So for sensory neurohearing loss, a CT scan does not typically have a place as a screening tool. So an MRI scan's usually what we would go to, if we're wanting to assess for the inner ear. And that's what I'm often deciding against when people get sent to me with hearing losses for a further screening, is do they need an MRI or not. His tinnitus, I don't know if people have a thing that they tell patients when someone comes with tinnitus. Audiologists are generally pretty good at tinnitus counselling. Amplification or using a hearing aid if someone has hearing loss, there's very good evidence that suppresses tinnitus. Even if they trial it for a month, there's suppression of tinnitus for up to 3 months afterwards for some patients. Masking sounds, you want a pleasantly distracting sound. You're not trying to blast over the top of the tinnitus really loudly. You're just wanting some gentle classical music so the brain has something else to latch onto other than their hearing trouble. Obviously, knowing that it fluctuates throughout the day, that doesn't mean they've got a disease process that's getting worse, and I tell them there are stresses that they just have to recognise will make the tinnitus worse. Decreased sleep, increased stress, very loud noise exposure. There are medications to avoid, and there are some that you could try if you wanted to. Aspirin, obviously, you can get rid of, as we mentioned, potentially if they're using high-dose paracetamol as well. And obviously if there's a medication that's started at the time of the tinnitus. If they have significant anxiety or depression, if they're going into a deep dark hole with their tinnitus, it is important to recognise that and obviously intervene early, which you will be much, much better at that than me. But like obviously once or twice a week I'll have patient come in obviously crying with their tinnitus, and there have been 1 or 2 patients that I've known that have killed themselves with tinnitus. Obviously consider treating their sleep issues, whether it be a temporary adjustment, they've come back overseas and they've had severe difficulty sleeping and their tinnitus is horrendous and it's a vicious cycle. Maybe they need melatonin until their sleep cycle's corrected. I would avoid long-term benzodiazepine usage. There's minimal evidence for vitamins, B vitamins and ginkgo biloba that they may help tinnitus. I tell patients you could try that for a month. If it helps a lot, great. If it doesn't, stop it after a month, otherwise you're paying for expensive urine. And obviously if that's not working, they need to see a psychologist or audiologist that has an interest in tinnitus that can give them CBT or tinnitus retraining therapy to try and gradually decrease the tinnitus. And that's, I usually say, look, there are these 5 groups of things and most of the treatments fall into that. You could, this is my little spiel, and give them an information sheet. So 5 years later, he goes, tries the hearing aids, loves them, the tinnitus gets a fair bit better with them on, but his audiologist sends back a letter saying, oh, he needs to see an ENT. And Albert's struggling really badly now despite his hearing aids. He's struggling enough that he's thinking of stopping work even though he doesn't want to. He's avoiding social situations, he doesn't go out to the pub, he finds phone calls are really difficult, and his tinnitus is worse in his left ear. He's a little bit more wobbly over the last 5 years now that he's beyond his 7th decade, and his audiologist sends that back. So obviously he's got a significant asymmetry of sensorineural hearing loss in the left ear now. I think, you know, obviously it's not rocket science, but I would have a look at him. He had an MRI. He doesn't have a vestibular schwannoma, which is what we typically think, but he did deserve to have a scan, and still 95% of people with significant asymmetry recognised by an audiologist won't have a vestibular schwannoma, but obviously all the maths that we have done on screening with MRI scans suggests that it's a good use of resources given the pathology that can occur. Yep.
How significant is cholesterol, hypertension in terms of vascular changes contributing to his hearing problem?
Yeah, so progressive or sorry, let me start again. Significantly uncontrolled hypertension definitely correlates quite highly with tinnitus. Hypercholesterolemia less so.
Hearing as well in terms of circulation?
Yeah, progressive hearing changes. Diabetes, there's a lot more evidence, and obviously smoking, that they have progressive sensorineural hearing loss over time. But the linkages, you know, we're talking years, same as a lot of the other risk factors.
Which is in his case.
Yeah.
And that's well controlled in his case?
Yeah, he was taking his medication and his blood pressure had been well controlled. I didn't have his other medications. I don't know that we're going to get through the last case, but basically after a full assessment, and an audiology workup for cochlear implantation is a lot bigger, we recommended that he did have an implant. Might skip quickly through this one, but basically I saw a young girl, 28-year-old accountant. She'd had pus coming out of her ear and decreased hearing. Wasn't too painful though. We'll skip that. But basically she'd had a balance off whilst the pus was coming out. She'd had background, the hearing was never quite right before she saw me with that right ear, so the hearing had been down for a long period of time, but it was down more so this year. And she'd had recurrent discharges, you know, for that last year. She knows if ever she goes into water, she'll get a yucky ear, so she avoids it. And she had this childhood period of grommets where she was one of those people that needed 4 sets of grommets. And we often find that with chronic suppurative otitis media or chronically discharging ears. There's almost a wilderness years for ENT surgeons with these kids. We look after them when they get their grommets, when their parents march them in dutifully to have their hearing tests and things done. Then from about the teenage years onwards, they're just lost. They don't come and see us. They don't get hearing tests. I don't know if they're seeing you guys with these problems. And then in their 20s or later down the line, they start to come back. Once these issues have re-emerged. This is what her ears look like. So, not subtle. Telling which ear is which, when you see it in a book or a paper, the handle of the malleus points on the paper to which side it is. That's pointing to the left of the screen, that's the left ear, and the anterior angle's quite tight. That's just significant tympanosclerosis on the mesotympanum with no other pathology. This, funnily enough, I bet that there are a large majority of training doctors I'll give an otoscope to that will not see this crust up here, because they'll put the otoscope in and they'll see this. We're getting these pictures with an otoendoscope, which has a really wide field of view, so you can really see a lot. But crust or wax on the eardrum is abnormal no matter which position it is. Usually it's cotton buds and they're shoving it down onto their eardrum, but the medial third of your ear doesn't produce wax. So that is like the top of the creme brulee on the top of a cholesteatoma, and you can see the little lump behind the eardrum there, or the white discoloration, which is where the rest of the sac of the cholesteatoma is growing in. So tuning forks, she's got a right-sided conductive hearing loss. She hears the Weber's test louder in that right ear. She has decreased hearing on the free field hearing test. She's got this funny thing called a positive fistula test, but I won't go into that now. So we do a hearing test. Right side, she's got a mixed loss. There's a little bit of sensorineural component, but mostly conductive because there's an air bone gap. Normal hearing on the other ear. which is good. And this is a CT scan, which would be reported as erosion of the scutum, which is the bone here, middle ear opacification, and labyrinthine fistula. So this is the lateral semicircular canal. It looks like a signet ring. That's obviously the ring portion, and that's the signet part. And there should be bone here, white bone, but the skin, which is this little sock of tissue here, is rubbed away and eaten into that bone. So she's at risk of losing her hearing entirely, and she was getting dizzy with loud sounds because the sound would go directly into the inner ear. So obviously she's got a cholesteatoma. This is an acquired cholesteatoma over time, and a lateral semicircular canal fistula. I treated her with surgery, expedited obviously to prevent inner ear trouble. She had what's called a canal wall down mastoidectomy, and then I obliterated the area I drilled away and repaired that defect in the semicircular canal. I think it's worth noting that cholesteatoma equals surgery unless they're very unfit for an operation, and then rarely we would just clean it out in the office over time. It's normally really slow growing, so we don't see cholesteatomas develop, within a month. Typically it's years, so they have an issue, in their childhood that then slowly grows over time. Even when we operate, if you send me a patient and say, oh look, this other surgeon was horrible, there's cholesteatoma there, I'm going to give them the benefit of the doubt. Even the best surgeons have a 1 in 10 recurrence residual rate because you only need a little bit of epithelium for it to grow back. So this is in Murtaugh. So there are two kinds of deafness. One is due to wax and is curable. The other is not due to wax and it's not curable. So come a little bit. But I love this quote being in there because Sir William Wilde is an otologist around the turn of the century who also said this. So long as otorrhea is present, we can never know how, when or what it may lead to, because people would just have a stinky ear in the past and then they'd die from meningoencephalitis, from a cholesteatoma or chronic suppurative otitis media. Everyone knows who this is? Oscar Wilde. That was his dad, who's an ear surgeon. Does anyone know what Oscar Wilde presumably died from? So syphilis and neurosyphilis was like the original theory until the Lancet put out this paper that thought he had a cholesteatoma, which his dad had also ignored. He'd had discharge out of his ear progressively for a long period. He had a radical mastoidectomy, which was done with a light in the hotel room and chloroform and a chisel. And that was 3 or 4 days before his death. So anyway, interesting. So last slide and then we're done. The NICE guidelines from the UK, I think, correlate well to general practice as far as when to refer on. So if they have a sudden onset within 3 days and you're sure it's not earwax or an infection, they need to see us urgently because it's probably a sudden inner ear hearing loss. Yep. So we're concerned about a sudden sensory neural hearing loss, and it's usually idiopathic. So the vast majority we don't find out. Sometimes we'll find out a precipitating event, like a vestibular schwannoma that's caused it, which is not unfrequent.
Should we start steroids or?
Look, I'm very happy if you have done a tuning fork test and you think that they have a sensory neural hearing loss to send them to get an urgent hearing test and give them prednisone orally as soon as possible. I do 50 milligrams for at least 10 days and then taper after that. Okay, so that's what I would do is if you've got the tuning fork confirmation or I suspect it clinically, I start them on steroids before they have a hearing test. But they still need to have an urgent audiological assessment. Obviously, if it's rapidly declining, you can kind of put it in the same bracket, which they say less than 3 months. So they say I was normal in January and now it's bad and there's no wax or a middle ear infection. If it's longer than that, so gradual onset, more than 3 months, they don't have any other worrying local signs, then you can relax a little bit, say you need to get a hearing test in the next few weeks and come back and see me and go from there. Low specific signs, so we said obviously sudden onset, but if they have obviously troubles with the trigeminal or facial nerve, they have signs that would indicate maybe it's just a tumour growing in one ear, so unilateral pulsatile tinnitus. If they've got signs of an invasive disease, so immunocompromised severe otalgia or noturia that doesn't go away after 3 days. If they've got a unilateral effusion that doesn't go away in an adult, we're worried about a nasopharyngeal carcinoma, so it's worth looking in the back of the nose. And obviously if they've got significant asymmetry, as we saw with our guy who came back. And obviously if the hearing doesn't get better once you fix the wax, or you've gotten their otitis externa better, the hearing should be back to normal, so once those things are gone. I'll skip through that. And yeah, so I really think, like I said, cholesteatoma and exostoses will be the two things that will be important not to mix up. And obviously they have different presentations. Exostoses, that water is really a part of their life. You can see it. The ear canal's abnormal. Eardrum with cholesteatoma, obviously. The ear canal typically looks normal or just has pus in it, and once that's settled down, you can see trouble with the eardrum. I'm eating into Dr. Bova's time, so I don't know if anyone else has any questions about things, but yeah, feel free.